Hello everyone. In this class, we'll learn about regulation of blood pressure by hormonal mechanism or long-term mechanism. The learning objectives would be appreciate the importance of sympathetic tone in regulation of blood pressure. Hormonal mechanisms. There are many hormones and chemicals that change the blood pressure by causing either vasodilatation or vasoconstriction. Catecholamines. In acute hypotension, stimulation of sympathetic fibers to adrenal medulla releases catecholamines. Catecholamines, especially norepinephrine, are vasoconstrictors. They also increase heart rate and cardiac output. Thus, catecholamines increase blood pressure. They increase blood pressure within minutes. Catecholamines injected as life-saving drugs in acute hypotension. These are some of the list of vasodilators and vasoconstrictors. So some of the vasodilators are endothelial derived relaxing factor, that is nitric oxide, bradykinin, histamine, atrial natriuretic peptide, VIP, CGRP alpha, substance P, prostacyclin, adenosine, potassium, acidosis, hypercapnia, hypoxia, temperature acts as vasodilators, whereas endothelin 1, angiotensin 2, norepinephrine, ADH, serotonin, thromboxane A2, neuropeptide Y, cold, they act as vasoconstrictors. Coming to renin-angiotensin system, fall in blood pressure stimulates the release of renin from JJ cells of the kidney. Renin converts angiotensinogen to angiotensin 1, which is further converted to angiotensin 2 by angiotensin converting enzyme, which is there in the liver. Angiotensin 2 is a potent vasoconstrictor that increases blood pressure. Angiotensin 2 increases synthesis and secretion of aldosterone, which increases sodium and water reabsorption from kidney. Angiotensin 2 stimulates thirst center to increase water intake. It also increases water reabsorption from kidneys and its direct action on the proximal carotid tubule. Renin-angiotensin aldosterone system is more involved in long-term regulation of blood pressure. Vasopressin. Decrease in the blood pressure and blood volume increases the release of vasopressin, that is antidiuretic hormone, from posterior pituitary. ADH increases water reabsorption from kidney that restores blood volume and pressure. ADH also causes vasoconstriction in supraphysiological concentration. Atrial natriuretic peptide. The ANP is secreted from atrial myocytes in response to stretch. Increased atrial filling due to the increased venous return stimulates secretion of ANP. ANP produces diuresis and natriuresis that decreases blood volume. ANP also causes vasodilatation that decreases blood pressure. Kallikrein-kinin system. Kinins that cause vasodilatation are bradykinin and lysyl bradykinin. Physiologically, kinins they resemble histamine. Bradykinin is formed from high molecular weight kininogen by the action of plasma kallikrein, which is formed from prekallikrein. Activated factor 12, that is Hegman factor of clotting system, acts on prekallikrein to convert into plasma kallikrein. Bradykinin is a potent vasodilator and decreases blood pressure. Bradykinin relaxes smooth muscles of blood vessels via nitric oxide. Bradykinin also increases capillary permeability and facilitates chemotaxis. Dicyl bradykinin is formed from low molecular weight kininogen by action of tissue kallikrein. Tissue kallikrein is present in pancreas, kidney, intestine, salivary glands, and prostate, and in many other tissues. Tissue kallikrein is located in the apical membrane of cells of these tissues and is involved primarily in transcellular electrolyte transport. Dicyl bradykinin increases tissue blood flow and mediates local inflammatory response. Histamine is a potent vasodilator and decreases the blood pressure. It is secreted from the mast cells. During anaphylactic reaction, histamine is released by dysregulation of the mast cells and causes acute hypotension. Endothelins. There are three different types of endothelin. Endothelin 1, that is type 1, type 2 and type 3. Endothelin 1 is formed from big endothelin 1, which also possesses endothelin activity. Endothelin 1 is most potent vasoconstrictor known so far. Veins are more sensitive to endothelin than the arteries. It is also potent positive chronotropic and inotropic agent that it increases heart rate and myocardial contractility. Thus, increase in blood pressure by causing vasoconstriction and uh, it increases the blood pressure by causing vasoconstriction and increasing the cardiac output. Endothelial derived relaxing factor. Endothelium derived relaxing factor EDRF is nitric oxide synthesized from arginine in the endothelial cells of blood vessels. Nitric oxide produces relaxation of the vascular smooth muscle and decreases blood pressure. Nitric oxide dependent vasodilators, histamine 1, acetylcholine, bradykinin, VIP, and substance P depend on EDRF for their vasodilatation. However, ANP, adenosine do not depend on EDRF for their vasorelaxation effect. Adrenomedulin. It causes vasodilatation by increasing synthesis of nitric oxide. Adrenomedulin decreases blood pressure and inhibits aldosterone synthesis. Coming to the long-term regulation of the blood pressure, mainly renal mechanism, the hormonal mechanism and the neural mechanism. Coming to renal mechanism, kidney controls the blood volume by controlling urinary excretion of salt and water. With alteration in the blood pressure changes, rate of excretion of sodium and water by kidneys that tend to restore blood pressure over days and weeks. Pressure diuresis and natriuresis. With increase in the arterial pressure from 60 to 200 mmHg, there is a progressive in water excretion, that is pressure diuresis, and sodium excretion, that is pressure natriuresis in urine. The curve depicting the relation between the arterial pressure and the urinary excretion is called as renal output curve. The output curve is less steep from 60 to 120 mmHg and more steep from 120 to 200 mm of Hg. Okay, so this is the renal curve where it shows the relation between the arterial pulse pressure, natriuresis, and the diuresis. As the atrial pressure increases, natriuresis and diuresis is going to increase, and till 120 the curve is less steep, and after which it becomes steeper. Salt content is the major determinant, that is salt intake. It has been well established that more salt intake is the main cause of chronically elevated blood pressure. Therefore, salt restriction of salt is the mainstay of treatment of hypertension and heart disease. Hypertension is not seen in tribes not eating salt. Salt preference and sensitivity. The contribution of salt preference and sensitivity to essential hypertension in human and experimental hypertension in models is well established. Salt preference is the more of liking salt food, which is more of social and cultural development, though hereditary also plays a role in it. Individuals with high salt preference are more prone to hypertension due to their increased salt intake. Salt sensitivity is the rise in the blood pressure due to the more response of blood vessels to salt in the body. Those who are more sensitive to salt, they tend to have more salt retention and develop hypertension even at normal salt levels of their blood. But usually people with salt preference are also more salt sensitive. Recent studies indicate that the close link of salt sensitivity to sympathetic activity. It has been reported that excess salt intake leading to salt retention increases the production of endogenous digitalis like factors that act centrally to increase the sympathetic outflow, increase the myocardial contractility to increase cardiac output, and cause proliferation of arterial smooth muscle and promote their contraction. And all these factors contributes to the genesis of hypertension. Some of the known EDLF are obane, digoxin, manibifagen, uh, and bifalins. These chemicals have a steroid nucleus and they promote contraction of vascular smooth muscle and myocardium by inhibiting sodium potassium ATPase. Hence, they are also grouped as cardiotonic steroids. Increased levels of EDLF have been reported to increase blood pressure in salt retaining individuals. Coming to the hormonal mechanisms, renin angiotensin aldosterone system. Fall in blood pressure increases the release of renin that causes angiotensin 2 formation. Angiotensin 2 is a potent vasoconstrictor and a potent stimulator for secretion of aldosterone. Aldosterone increases salt and water reabsorption from kidney and increases blood pressure by long-term mechanism. Aldosterone is a major long-term regulator of blood pressure. Antidiuretic hormone. When blood volume decreases, ADH secretion from posterior pituitary increases. ADH increases water reabsorption from kidney and increases blood volume and pressure. It also causes vasoconstriction in supraphysiological concentration. ANP, increased blood volume increases venous return that increases synthesis of atrial natriuretic peptide in atrial myocytes. ANP causes natriuresis and diuresis that decreases blood pressure. Some of the neural mechanisms like baroreceptor resetting and central adaptation also play important role in the regulation of long-term blood pressure. In chronic hypertension, baroreceptors are reset to regulate the elevated blood pressure. The firing rate of the baroreceptors decrease in response to chronic hypertension. Medullary cardiovascular centers also adapt to the elevated pressures. Role of sympathovagal balance. Emotional responses of body and responses to the environment are major stimuli for alteration in blood pressure. These responses are executed through autonomic nervous system. Autonomic nervous system executes its functions through its two important subdivisions, that is sympathetic and parasympathetic systems. Sympathetic system is involved in energy mobilization and utilization, and parasympathetic system is energy restoration and the storage. Although these divisions of the ANS are physiologically opposite, they are reciprocal to each other in their own in their outflow and the functions. In healthy individuals, sympathetic and parasympathetic systems are in a state of dynamic balance known as sympathovagal balance, which contributes to effective internal homeostasis. So this is in brief about the long-term regulation of the blood pressure, mainly by the hormonal mechanisms. Thank you.